So today we'll discuss one of the important diseases that are frequently found in the outpatient department as well as the indoor wards of the hospitals. That is gastroesophageal reflux disease, in other way called the GERD. This is very common, and this disease can mimic some other diseases, and you have to know how to differentiate them. Okay, so you have to know very in details regarding the GERD, as this is very common. So, first of all, what is GERD? In a simple term, if I say that is, it is one of the forms of esophagitis. Okay, the esophagitis can occur in many ways, and the esophagitis that we find in the gastroesophageal reflux disease is due to the acid in our stomach or due to the pepsin that acts in our stomach. It can be also due to the bile as well as the pancreatic enzymes. Okay, so gastroesophageal reflux disease, this esophagitis, is usually caused by four important factors, that is acid, pepsin, bile, and pancreatic enzymes. The esophagitis can occur in other ways like infections, corrosive agents, but in the gastroesophageal reflux disease, we have to remember that it is occurred by four important factors, that is acid, pepsin, bile, and pancreatic enzymes. So, what are the factors that are associated with the gastroesophageal reflux disease? If I simplify here, you can see a figure here. This is the esophagus and this is the stomach. So the lower esophageal sphincter plays a vital role in developing the gastroesophageal reflux disease. If there is dysfunction in the lower esophageal sphincter in the here, there will be reflux disease. So how it occurs? If you see the lower esophageal sphincter have some dysfunction, like it its tone is reduced and it is associated with inappropriate relaxation. So what will happen? The contents in our stomach will jump into the esophagus and it will cause the reflux disease. Okay, so if you have the sphincter, okay, your sphincter is fine, but you have an increased intra-abdominal pressure that can occur in many ways. If you strain, if the central obesity and pregnant women, these conditions can raise the intra-abdominal pressure and it will ultimately compress the stomach upwards and the pushing the contents of the stomach back into the esophagus and ultimately causing the reflux disease. If you have a delayed gastric emptying, the food content in the stomach are not emptying properly or they are delayed. So it will be in long term staying in your stomach, and if you bend or if you lie down on bed, then the food content may jump back into the esophagus and cause the reflux disease. Okay, so these are the important factors. So what happens? The esophagus itself has some problem. Like if the esophagus is defective, like there is some dysmotility disorder of esophagus, there the food content cannot pass the esophagus properly and it will cause the reflux disease. Okay, there are some environmental or the dietary factors, lifestyle factors that are related with the reflux disease. So what are they? Some food content like tea, coffee, coffee, alcohol, chocolates. Okay, these are the important dietary factors: tea, coffee, alcohol, and chocolates. These foods, this type of foods, have an effect on the lower esophageal sphincter here. It relaxes the lower esophageal sphincter. So if you drink tea or coffee just after you have a heavy meal, it will relax the lower esophageal sphincter, and ultimately the food you have eaten will jump into the esophagus and it will cause heartburn, regurgitation, and reflux disease. Okay, so there are some lifestyle factors related with the reflux disease. An important condition that is hiatus hernia. It also causes reflux disease. So we have discussed about the many factors and the associated conditions regarding reflux disease. In this way, the reflux disease can occur, and what are the presentations, how the reflux disease present. The principal symptoms are like heartburn. Often people complain they have heartburns during night. The heartburns in reflux disease is aggravated by bending, if you strain during defecation, or you do some strain in weightlifting works, in other way, any kind of straining, or lying down. Some people say they have only the heartburn during the bending, straining, or when they lie down on bed. They have heartburns. So these are the principal features, are very frequent features of the reflux disease. As I have mentioned earlier, reflux disease are affected by obesity. Okay, and it is more common in older people. Some older people say that they have frequent pneumonia. In this case, you have to consider the gastroesophageal reflux disease as an important factor in old age to develop frequent pneumonia or chest infection. So, how the recurrent pneumonia occurs in reflux disease? Like in the reflux disease, the acidic content of the stomach jump back into the larynx and it enters the respiratory tract. In that way, it can cause respiratory tract infection, in other words, chest infection or pneumonia. And it is more commonly found in old age. In older people, the sphincter, that is lower esophageal sphincter, it becomes lax. Okay, it becomes loose. So there is frequent regurgitation of food content of the stomach into the esophagus. That is why in the old days there is recurrent pneumonia and it can occur from gastroesophageal reflux disease. Okay. Now, There are some important conditions that are associated with the reflux disease, like the patient can have atypical chest pain and it can mimic like heart attack or even angina. Okay, so why the angina type pain occurs in reflux disease? It causes esophageal spasm. Okay, the acidic content or the contents of the stomach jump back into the esophagus and it causes esophageal spasm. And as it is lies in the mediastinum of a chest, so it can cause central chest pain that can mimic heart attack or angina. Okay, okay. So in that case, if you do a simple ECG or troponin I, you can easily differentiate it from the heart attack. Okay, this is very common. People usually say they have chest pain, and if you find the cardiac investigations normal, like ECG normal, troponin I normal, or the echo normal, then you can label it at gastroesophageal reflux disease. Okay, like I have mentioned earlier, these patients have acid laryngitis. The reflux contents enters into the respiratory tract and then it causes acid laryngitis. Okay, and when the people of GERD having a hoarseness of voice, you can say the hoarseness is due to the acid laryngitis, recurrent chest infection, and it is associated with chronic cough as well as asthma. Okay, so these are the important conditions that are associated with the reflux disease. It can mimic like angina or even heart attack. It is associated with acid laryngitis, that is hoarseness of voice. It can cause a recurrent chest infection from the aspiration of gastric content. It is associated with chronic cough. As you know, there is a reflux, so it is irritable for the respiratory tract. The gastric contents are irritable for respiratory tract, so it can cause chronic cough. Okay, and there is also association with asthma. So these are the important conditions you have to remember when you are dealing with the uh, the gastroesophageal reflux disease. Okay, here you can see and figure like endoscopic findings of a reflux disease. Like you see, there are some circumferential ulceration. Okay, you are seeing circumferential ulceration in the esophagus that extends upwards. Okay, so this is the endoscopic finding of reflux esophagitis or gastroesophageal reflux disease. So what are the complications that can occur? As I have mentioned earlier, the gastroesophageal reflux disease is a form of esophagitis. Okay, so it causes esophagitis, and if the long-term esophagitis persists, there can be stricture. Okay, and it can develop Barrett esophagus. You probably know the Barrett esophagus is a pre-malignant condition. When the Barrett esophagus occurs, there is change of lining, okay, and the squamous lining of the esophagus is replaced by the columnar mucosa. Okay, so Barrett esophagus is a pre-malignant condition, and there are some association with carcinoma or cancer. As you know, the reflux of bile, acid, pepsin, and pancreatic enzymes These are important pathogenesis. These are important pathogenetic factor for developing the cancer. Okay. There are some important other factors like promoter hypermethylation, inactivation of TP53, aneuploidy, inactivation of tumor suppressor gene, that is P16. These are also related with the development of cancer. Okay. Okay. Here you can see the endoscopic finding of Barrett esophagus. As you can see, here is a pink colored columnar mucosa extending upwards. This is a how a Barrett esophagus looks. Okay. So how you diagnose the Barrett esophagus? The endoscopy of upper GI tract. Okay. You do a simple endoscopy and you can diagnose the Barrett esophagus. Okay. Regarding the management of Barrett esophagus. So there is an important note, okay, that the acid suppression or the anti-reflux surgery, it doesn't uh, stop the progression of Barrett esophagus. These treatments are done in case of Barrett esophagus only for the relief of symptoms. Okay. An important feature, that is anemia, and it can cause iron deficiency anemia. Okay, as there are occult blood loss from the long-standing esophagitis. It causes esophagitis. There are infections. There can be inflammations. Okay, and there are occult blood loss, and that causes iron deficiency anemia. So if you find a people with the features of GERD like heartburn, regurgitation, like they have heartburn when they bend, when they lie on bed, and if you uh, find on his routine investigations like complete blood count, if you see the hemoglobin has been reduced and it is of microcytic hypochromic anemia, so you have an important clue that this is a iron deficiency anemia and association with the reflux disease. So in this case, if you find the esophagitis in endoscopy, you have to also consider the colorectal cancer. Okay, so in that case, we have to also do the colonoscopy. Okay, to exclude the colorectal cancer. Right? I repeat, if you find the people with GERD with iron deficiency anemia, so how you find iron deficiency anemia? On his routine investigation, the complete blood count shows hemoglobin is reduced and it is microcytic hyperchromic anemia. On endoscopy, there is esophagitis. So you have to exclude the colorectal cancer by doing colonoscopy. Okay, this is an important uh, part of management. Okay, now it can cause the esophageal stricture. Okay, in the long standing esophagitis, it can cause ultimately the stricture. So how you know the patient has esophageal stricture? The patient will complain of dysphagia. Okay, the people of heartburn, when they complain they are having dysphagia, that means they have developed the esophageal stricture. Okay, it can be seen in endoscopy. Okay. Now, an important situation, gastric volvulus. This is very important. Like if a patient with the features of GERD or gastroesophageal reflux disease develops severe chest pain, vomiting, dysphagia, then your important differential should include the gastric volvulus. Okay, the patient with the features of GERD suddenly develops severe chest pain. You have two differentials. As I have mentioned earlier, the GERD can mimic the heart attack or angina. Okay, and it can also cause the gastric volvulus. Okay, in these two important situations, the people of GERD can develop chest pain. Okay, as it can mimic the heart attack by esophageal spasm, and it can develop gastric volvulus. Okay, so how you differentiate these two? If you do a chest x-ray, you can see air bubbles in the chest. If you see the air bubbles in the chest, your diagnosis is gastric volvulus. Okay, so I repeat, if a patient of gastroesophageal reflux disease, he is having features like heartburn, regurgitation, on bending, on straining. He's having a recurrent chest infection. His old age, and he develops severe chest pain. You have two important DD. It can be esophageal spasm, and it can mimic like angina. Secondly, it can be gastric volvulus. Okay, so if you do a simple chest x-ray, if you see the air bubble in the chest on the chest x-ray, your diagnosis will be gastric volvulus. Okay, but if your chest x-ray is normal, you can do the barium swallow to diagnose a gastric volvulus. If these two are normal, then you can say that yeah, the patient with GERD developed chest pain. So his chest X-ray and barium swallow are normal. So it is like esophageal spasm that can mimic like angina. Okay. So in the gastric volvulus, in the acute phase, you have diagnosed that yeah, this is a case of gastric volvulus. So in the acute phase, what do you do? You just insert a nasogastric tube or NG tube in the acute condition, and it can facilitate decompression. Okay, it can facilitate decompression, and thereafter the acute phase, after the acute phase is over, there can be endoscopic decompression. Okay, so gastric volvulus is a very important association with the gastroesophageal reflux disease. Okay, now we're moving on to the investigations of gastroesophageal reflux disease. Simple investigation, there are three important investigations. First of all, the endoscopy. It is the investigation of choice. Okay. Secondly, you can do esophageal pH monitoring. Okay. Thirdly, you can do impedance testing. Okay, impedance testing. So three important investigation. Number one, the endoscopy. Number two, the esophageal pH monitoring. And number three, impedance testing. So when you do the impedance testing, if you see that esophageal pH monitoring cannot detect the reflux disease, but you're confused, okay. But the esophageal pH monitoring, by doing esophageal pH monitoring, you do not reach to a conclusion, okay. In that case, you do the impedance testing, okay. The weakly acidic or weakly alkaline reflux cannot be diagnosed by esophageal pH monitoring. If there is a minimal reflux, the minimal reflux, uh, the pH will not change, okay. So if you see the esophageal pH monitoring uh, is not giving you any conclusion, then you can move on to the impedance testing, okay. Now let's move on to the management, very important. So what will be management? First of all, there will be non-pharmacological management, that is lifestyle modification. This is very important. Without lifestyle modifications, the symptoms of GERD cannot be relieved properly. Okay, so what lifestyle modification advice you have to give to your patient? You can advise for weight loss. There should be dietary avoidance of tea, coffee, chocolate, alcohol, fat content diet. These are dietary factors that can provoke the reflux disease. So these foods should be avoided. Okay. Elevation of bed in the head side. Okay. The people in the old age, or the people that complains the heartburn when they lie down, so in those patients you have to advise them, to elevate the bed in head side, okay. So they will not have the regurgitation, they will not have the uh, uh, contents of the stomach jump back into the esophagus, okay. So you have to advise them to elevate the bed in head side, okay. Also advise to avoid late meals, okay. If the people with reflux disease having a late meal and with the full stomach go to the bed and goes to sleep, he will have nocturnal symptoms. So you have to advise to avoid late meals, okay. And also, least but not last but not the least, the cessation of smoking. Smoking should be stopped. So these are the important lifestyle modifications for the people with gastroesophageal reflux disease. Okay. Some people advise that H. pylori eradication therapy injured, but there is no such evidence that H. pylori eradication has any therapeutic role in gastroesophageal reflux disease. But in one situation, like if the people observed needs long-term PPI therapy, that his or she is having PPI, proton pump inhibitor therapy, more than 1 year, he is having or she is having proton pump inhibitors for more than 1 year to relieve the symptoms of reflux disease, then he or she is indicated for H. pylori eradication therapy. Okay, the long-term PPI therapy can have some problems, like it reduces absorption of iron, so there can be iron deficiency anemia. It reduces absorption of the vitamin B12. It reduces absorption of the magnesium. Okay, if the people having long-term PPI therapy, there will be reduced iron, B12, magnesium in his body. Okay, and it can also predispose to some infections like salmonella infection, campylobacter, clostridioides difficile infection. These infections are associated with the PPI or proton pump inhibitor therapy. It can also cause microscopic colitis as well as acute interstitial nephritis. So nowadays the PPI is a very common medicine. Okay, people um, they are frequently taking PPI as per need. So these are the important conditions that can occur with long-term PPI therapy. Okay, so you have to remember, and the people are having PPI therapy more than 1 year, he or she is indicated for H. pylori eradication. Okay, but with the simple diagnosis of GERD, the people not having PPI more than 1 year, there is no evidence that H. pylori therapy is indicated in this case. Okay, so what are the other drugs you can use in the GERD? Okay, you can use some antacids, alginates, proton pump inhibitors, H2 blockers. Okay, this is the medical therapy. Okay, and if the medical therapy is not effective, or the people that are not willing to take long-term medical therapy, then there can be laparoscopic fundoplication. Okay, here you can see uh, that medical management, like if they have symptoms, they can use antacid or alginates. Okay, the proton pump inhibitor at full dose. If they have good response, you can do a step down. Okay, the proton pump at maintenance dose. Okay, then you can switch to H2 blocker and then antacids. Okay, and if they have poor response or side effect, or they are not willing to get the medical therapy, you can do the fundoplication. So you see, the reflux disease is a form of esophagitis. Okay, so what are the other cause of esophagitis? Like there can be infection, candidiasis, that can be associated with AIDS. Okay, some corrosive agents, like the people are doing suicidal attempts, they ingest the caustic agents or alkaline agents, and they can also cause the inflammation and the esophagitis, and uh, lately they develop the esophageal stricture. Okay, some drugs, these are very important, some drugs can cause esophagitis also, like potassium supplement, NSAID. Okay, bisphosphonate, these drugs can cause esophagitis, tetracycline, doxycycline. So before prescribing these type of drugs, you have to exclude that the patient is having esophagitis or not, any sorts of esophagitis or not. Okay, before prescribing potassium supplement, NSAID, bisphosphonate, tetracycline, doxycycline, you have to exclude the patient is either having esophagitis or not. Okay, an important condition is eosinophilic esophagitis, and in this case, the endoscopy is usually normal. So if you see a people having symptoms of reflux disease or symptoms of esophagitis, if the endoscopy is normal, still biopsy should be taken. Okay, the eosinophilic esophagitis is in this case the endoscopy can be normal. Okay, what are the findings that are expected in eosinophilic esophagitis? Mucosal ring, longitudinal furrows, exudate, edema, stricture. This can be found on eosinophilic esophagitis, but it can be normal. So if there is normal findings, the biopsy should be taken. Okay. So on the histology, what you see, there is greater equal 15 eosinophil in the histology. Okay, here you can see a endoscopic feature of eosinophilic esophagitis. It can look like this. Okay, so in this case, what will be the treatment? If your diagnosis is of eosinophilic esophagitis, first you do the treatment with 8 weeks of proton pump inhibitor therapy. Okay, if the response, then it is called the PPI or proton pump inhibitor responsive esophageal eosinophilia. But if they do not respond, the what will be the treatment plan? If they do not respond with the proton pump inhibitor, then there should be 8 to 12 weeks therapy with topical glucocorticoid. And this glucocorticoid can be either fluticasone or budesonide. Okay, and how this is taken in this case of eosinophilic esophagitis, you tell the patient to swallow the spray. Okay, if you do endoscopy, if you find esophageal wave and the person have iron deficiency anemia as well as dysphagia, so this is a triad, and this triad is called the Plummer Vinson syndrome. Okay, so this is all about the esophagitis and reflux disease. I hope the lecture will be helpful for you in your clinical practice, as well as if you want to attend different exam, different medical exam in medicine faculty, it will be helpful for you. So thank you.